Hello, Clinic Review families. Dr. Sharon. Today we're talking about hyperemesis gravidarum. You can find it in the Blue Book. The section on hyperemesis gravidarum in the Blue Book is pretty short. I'm expanding on it just a little bit, so let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe. Mark Clinic does that NCLEX online on-demand NCLEX review. It is good for RNs and PNs. I get that question quite a bit. If you do it as a PN, you're going to be a little over-prepared. You're going to find the PN exam, pretty, you're going to be successful on it. But you can also use it for either one you want to. And we also have a streaming service where you get the videos I put on YouTube. You get all those videos for without any commercials. And there's probably at least 10 extra videos on the streaming service. We don't cover the NCLEX review content in these videos or in the streaming service. It's totally different content. Primarily, the streaming service is for you to learn some information and to practice questions. And then we have our small group tutoring. You can buy it as a monthly package. All right, let's go ahead and get started. Hyperemesis gravidarum is specific to pregnancy. It's severe prolonged vomiting. So let's go ahead and look at some questions so you can learn about it as we go. A 28-year-old client at 12 weeks gestation presents with excessive nausea and vomiting. She's lost 5% of her pre-pregnancy weight and has ketonuria, which is ketones in her urine. Which of the following is the most likely diagnosis? Normal pregnancy, early pregnancy nausea, hyperemesis gravidarum, gastroenteritis, cholestasis of pregnancy. All right, well, obviously you know what the right answer is since we're doing hyperemesis gravidarum here, but let's talk a little bit about the difference between normal pregnancy nausea and hyperemesis gravidarum. So hyperemesis gravidarum is severe and prolonged into the second trimester, whereas early normal pregnancy nausea is not nearly so severe, and it does not go into the second trimester. A client at 14 weeks gestation has been experiencing severe vomiting and is diagnosed with hyperemesis gravidarum. The nurse understands that which of the following is a key differentiation between hyperemesis gravidarum and normal morning sickness. Oh, well, I already told you the answer to this. Hyperemesis gravidarum usually resolves by the second trimester. Wrong. That is normal morning sickness. A is normal morning sickness. Hyperemesis gravidarum does not require medical intervention. That's false, actually. One of the key factors of hyperemesis gravidarum is it's such severe vomiting with dehydration, and sometimes can even lead to starvation and acid-base imbalances that it does require medical intervention. Hyperemesis gravidarum is psychosomatic in nature. It is not, although there can be a psychosomatic component to it, but it is not psychosomatic in nature. Hyperemesis gravidarum is severe and prolonged. That's the correct answer. For women who are very upset about being pregnant, or they are in denial about their pregnancy, or I don't know, they have a lot of emotional feelings associated with it. It often does make their nausea and vomiting worse, but it doesn't always lead to hyperemesis gravidarum. So when I say there could be a psychosomatic component to it, that's what I mean by that. A client with severe hyperemesis gravidarum has been unable to eat adequately and is showing signs of starvation. Which laboratory results should the nurse monitor closely for to assess for starvation-induced complications? Blood urea nitrogen, serum albumin, serum glucose, or serum ketones? Well, I'm going to rule out blood urea nitrogen. That's a waste product, so I don't know that BUN goes up with starvation. Serum albumin, that does go down with malnutrition, so we can leave that on the list. Serum glucose does go down with starvation, so we'll leave that on the list. Serum ketones. Now, serum ketones go up when fat is being metabolized for energy in the absence of glucose. So when glucose is metabolized for energy, it releases a substance called acetyl-CoA. And acetyl-CoA enters the fat metabolism cycle and allows fat to be metabolized with low waste. The waste product of fat metabolism is ketones. So if you have glucose metabolism or carbohydrate metabolism in alongside fat metabolism, then you don't release a lot of ketones. But if you have fat metabolism without carbohydrate metabolism, you release a lot of ketones. And one of the things about starvation is they do tend to become ketotic. So you can have a low serum albumin and a low serum glucose and not be starving. You may be malnourished, but not necessarily starving. Whereas serum ketone goes up, that is an indication of starvation. So we're going to pick that one. A nurse is providing dietary counseling to a pregnant client who struggles with mild hyperemesis gravidarum. Okay, I don't know what mild hyperemesis, maybe it's the kind that doesn't need intervention, but okay, whatever. Which recommendation might help reduce her nausea and vomiting? Include ginger in her diet. I don't know. Avoid all carbohydrates. Well, I know that's not true because if she avoids all carbohydrates, she's going to starve. So that's out. Only eat 3 large meals a day. I know that's not true because large meals is more likely to induce nausea and vomiting, whereas frequent small meals would be better. Drink fluids with meals to speed up gastric emptying. Drink fluids with meals to speed up gastric emptying. I don't know. I don't know how that would help with nausea. It seems like if you drink a lot of fluids, you're going to fill up with fluids and you're not going to get the calories that you need. So I don't know if ginger in the diet is helpful. It seems to me like ginger has been used to treat nausea because isn't ginger ale given to people? Like I've given ginger ale to my patients before who are nauseated to help them. So for me, it makes sense that ginger could possibly help. Now, doesn't mean it's always going to help. I don't know. I don't know what the statistics are on helping, but it makes sense. And I know B, C are bad. B and C are out. And I know D is not a good option because if we tell her to just drink lots of fluids, she's not going to get as much food. She's going to fill up on fluids. And I don't know that it's going to help with nausea. So I'm going to go ahead and pick ginger in her diet. So when you get a question that you're not quite sure about, don't immediately cross off an answer. Do you go, I've never heard of that? No. Okay, if you've never heard of it, so go, well, maybe. Let's see what the other answers are. One of the mistakes, and Mark talks about this in the interview I have with him posted on our YouTube channels. He talks about people who preemptively cross off answers. So don't preemptively cross off answers. Keep them like as a question mark of maybe. Maybe that's an option until you see what the other answers are. A pregnant client with hyperemesis gravidarum asked the nurse why she can't take oral liquids yet and has to receive IV fluids. What is the best response by the nurse? So early on, when they're first admitted with hyperemesis gravidarum, we rehydrate with IV fluids. We usually keep them NPO for a short period of time to kind of rest the gut. So let's see what the answers are. Your vomiting has been severe and it's important to rest your stomach before giving you anything by mouth. All right, that's probably not how I would say it, but that is true. B, this is the healthcare provider's standard orders for anyone with hyperemesis gravidarum. So that's just not a good answer. That's not client focused. It's not therapeutic. So just because something may be true doesn't mean it's therapeutic and it's not helpful. So I don't like B. As soon as your laboratory values are normal, you'll be allowed to drink clear liquids. I don't think that's what makes that decision. Your baby's health depends on you receiving fluids IV first. Is that true? Let's see. I'm going to cross off B and C. So let's compare A and D. Let me see. What is the best response about why she can't take oral fluids? Your vomiting has been severe and it's important to rest your gut or stomach before giving you anything by mouth, or your baby's health depends on you receiving fluids IV. So I like A better because that explains why, as opposed to just saying, D is almost like a don't worry about it. It's for your baby's health. It's not explaining why that is. So A, I like as a better answer. The nurse is educating a client with hyperemesis gravidarum about dietary changes to help manage her condition after discharge. Which recommendation is appropriate? So HG after discharge. Consume high-fat foods to slow gastric emptying. That doesn't seem like a good idea. Eat a large meal every few hours to maintain blood sugar levels. Large meals are not a good option with nausea, just in general, and not just talking about with hyperemesis gravidarum. Drink small sips of fluid with dry fluids like crackers. That seems like a good idea. That keeps kind of a consistent fluid and foods and fluids without putting too much in. Avoid eating protein sources. I don't know why you have to have protein for the baby to grow. You have to. So that doesn't seem like a good idea. So out of these options, C is my best option. And it's pretty consistent with like what I know to be true, where we keep them NPO, or if it's not as severe and we can send them home, or we're getting ready to send them home, we're going to teach them about smaller amounts, sips with crackers, like a dry carbohydrate kind of a thing. So that's a good option. A nurse is evaluating the lab results of a client with hyperemesis gravidarum, which finding is consistent with the diagnosis. Elevated liver enzymes, low urine specific gravity, elevated hemoglobin and hematocrit, or metabolic acidosis. Okay, so liver enzymes, I don't know why those would be elevated. I just, to me, I don't, it's not something I'm familiar with, so I'm going to cross it off for now. Low urine specific gravity. So low means the urine is more dilute. It means it has more water in it. And if they're dehydrated, they're not going to have a low urine specific gravity. They'd have a high urine specific gravity. So B is out. Elevated hemoglobin and hematocrit. So one of the reasons H&H can be elevated is serum concentration or hemoconcentration. So when you lose a lot of fluids in a quick period of time, not blood, you're losing blood. Okay. They're not bleeding out. They're bleeding out, their H&H is going to go down, but they're losing vascular volume. Their H&H can actually go up because of concentration. So I like C, metabolic acidosis. Metabolic acidosis is not the answer. It is a metabolic problem, but it's not metabolic acidosis. And we've got another question coming up, so I'll talk about why that is in another question. So that's hemoconcentration is the reason for C. The nurse is caring for a pregnant client with hyperemesis gravidarum who's dehydrated. Which IV solution would the nurse expect to be prescribed to correct dehydration? 0.9, D5 water, half normal saline, or LR. So I don't think you'll get a question exactly like this, because honestly, you could do A or D. A or D would be fine, and it's really up to the prescriber. But I will tell you that on the NCLEX, normal saline is almost always the right answer. And the reason it's the right answer is because 0.9 normal saline is isotonic. Now, LR is also isotonic. However, on the NCLEX, they prefer normal saline. It's isotonic, which means it can expand vascular volume without moving fluid around a lot, right? If it's hypotonic, then fluid is going to leave the vessels and can enlarge the cells. And if it's hypertonic, it's going to pull fluid in and dehydrate the cells. So isotonic solution allows you to increase vascular volume without moving fluid around a lot. And the key thing, you got to understand, the key thing here is dehydration. They didn't say they were hypoglycemic. Okay, if they're hypoglycemic, I'd probably do D5-4-5 because I'd want to add some water or some dextrose to that. So that's probably what I would do. But this person is just simply dehydrated, and the best option for expanding vascular volume is 0.9. The nurse is caring for a client with hyperemesis gravidarum, which acid-base imbalance would the nurse watch for? Okay, here's the one I was telling you about. So when they give you a scenario and then they say, which acid-base imbalance is it? Here's how you answer that question. First of all, you say, is it a respiratory problem? If it's a respiratory problem, then cross off the metabolic options, okay? This is not a respiratory problem. This is a vomiting problem. So we're not going to pick A or B. So those are out. Now, the question is it acidosis or alkalosis? Well, as far as GI is concerned, I always say, because this is what helps me, upper GI, think up. Upper GI is stomach and up. So emesis is stomach and up, right? So emesis or upper GI is up. So think up pH. Up pH is alkalosis. Lower GI, like diarrhea, lower GI is a downward, lower, down. So think low pH or acidosis. So hyperemesis gravidarum is upper GI, it's vomiting. So we have to have our pH go up. And it's not lung, it's not respiratory, so it has to be metabolic. So the answer is metabolic alkalosis. Now, I'm not explaining to you all the whys and hows and the pathophysiology of that. And that's because this is an NCLEX prep channel. I'm helping you prepare for NCLEX, and I'm helping you learn how to answer the questions so you can get them right. If you work in a place where you have hyperemesis gravidarum patients, you probably want to figure out why they're experiencing metabolic acidosis. And maybe at some point, I think I talk about it more in some of my acid-based lectures, but I'm just not going to talk about it here because it doesn't really need to be talked about here. A pregnant client at 10 weeks gestation is being treated for hyperemesis gravidarum. She asked the nurse why she needs to receive vitamin B6. What is the nurse's best response? Vitamin B6 helps to reduce nausea and vomiting. Vitamin B6 improves the function of your liver. Vitamin B6 prevents neural tube defects in the fetus. Vitamin B6 helps regulate your blood pressure. So I know C is out because folic acid is what prevents neural tube defects. So I'm crossing that off. Now the question is there a liver or blood pressure problem with hyperemesis gravidarum? Well, there could be a blood pressure problem, but I've never heard of vitamin B6 regulating blood pressure. And listen to me, if I'm going to use my common sense, and you cannot throw your common sense out the window, if I'm going to use my common sense, I say to myself, this is a vomiting problem. Why else would I give vitamin B6 other than to reduce nausea and vomiting? So this is a common sense question. Even if you didn't know vitamin B6 can help, which honestly, I didn't know vitamin B6 could help, but I could still get it right because I use my common sense and I say, why would I pick anything else other than reducing the problem that they're admitted for? A pregnant client with hyperemesis gravidarum has lost 8% of her pre-pregnancy weight and now presents with fatigue and weakness. Which electrolyte imbalance is the most likely cause of these symptoms? Well, fatigue and weakness are associated with any kind of electrolyte imbalance, but she's vomiting. So we're going to think that she's vomiting up a lot of those electrolytes in her gastric acid. So there's a lot of electrolytes in the GI tract. So if she's vomiting those up, she could be vomiting up potassium. She could be vomiting up sodium as well, honestly. I suppose she could be vomiting phosphate and calcium. However, I think it's more likely she's got a hypo problem because if she's vomiting stuff up, and it's more likely just because I know how NCLEX tests. They're not testing me on hypophosphatemia here. They want to know, watch for electrolyte imbalances, and which electrolyte imbalance are you more likely to see here? And it's more likely to be hypokalemia. So that's the correct answer. Oh, I changed it to hypo. Don't worry about it. I would still, no matter whether the natremia was hyper or hypo, I would have still picked hypokalemia, because that's the most common problem and more likely to cause fatigue and weakness. In hyperemesis gravidarum, which factor is most commonly cited as a contributing cause of the severe nausea and vomiting experienced by the client? Elevated HCG, high levels of estrogen and progesterone, decreased thyroid hormone levels, stress, and psychological factors. Well, I don't think it's likely to be C or D. So it's either going to be elevated HCG or elevated estrogen and progesterone. And, there's a lot of other reasons people can have high levels of estrogen and progesterone and they don't have hyperemesis gravidarum. It's only with pregnancy really that you see elevated HCG levels. So that's a pretty good guess. Now, let me tell you why that actually is the correct answer. So HCG levels are elevated in multiple pregnancies. So multiparity is a risk factor for hyperemesis gravidarum. The other thing that's a risk factor is a molar pregnancy. A molar pregnancy is when, for some reason, the cells of the placental cells grow more than they should, and sometimes they can cause little, I don't want to say tumors, but they're benign, but they're like little tumors. When you have that increased level of placental reproduction, you have increased HCG levels. That's what a molar pregnancy is. And just so you know, molar pregnancies, sometimes there's a fetus and sometimes there's not a fetus with a molar pregnancy. And even if there is a fetus, it is never, they're not able to come to term. So molar pregnancies are associated with no actual pregnancy. And then multiple pregnancies is also a risk for hyperemesis gravidarum. All right, that's it. I hope that was helpful to you. And I hope you have a great rest of your day. Thanks for being a part of the Clinic Review family. Good luck on your NCLEX or your standardized tests, whatever you're taking. Watch some of our other videos. And thank you for watching to the very end. Love you guys.